These are OBG questions. The first round, first set of questions are OBG questions. The second set of questions will be medicine questions. No? The answer is the first person is Irving Freeler-Steen and Michael Leventhal, who described the term PCOS in the year 1935. Steen Leventhal syndrome. Next, the third question goes to the third team, Bima. Likely cocktail is named after.
You one. I can.
You want to try?
I will give it.
You want me to tell the answer? Answer is Krishna Menon. The likely cocktail includes penicillin, chlorpromazine, and promethazine, used in eclampsia. The fourth question for fourth team, Tungabhadra. First successful IVF pregnancy was in the year 1978 in the world. Yes. That is Louis Brown. Right answer. It was on July 25, 1978, done by Dr. Patrick Steptoe and Dr. Robert Edwards in England, and the baby born was Louis Brown. The next question for Team 5, Godavari. Transgender Protection Act was enacted by Government of India in the year 2000. No. It's a wrong answer. The right answer is Jan 10, 2020. The act was introduced in the Parliament in 2019 and was enacted in 2020. The next question is for Team 6. That is Shanavati. First established symptom of diabetes as described by the historians.
Audience. I can. What? Speed I not rest.
Polydipsia. Wrong answer. It is increased frequency of maturation. Polyuria. The next round. Can you hear me? I think if you had seen Munnaba MBBS, you would have answered that. I think nobody has seen Munnaba. He says that in that very specifically that polyuria. So that is whenever we see films, the people who make films are actually we think they are dumb, but they are quite smart. They are people who know the ground reality far much than what we know. At the end of every round, we have an audience question, and we are going to give a small gift, and it is not a chocolate. And yes. Okay. So, who are the questions are there? Okay. Yes. So, who point? So, we are talking about hormone. Who? Okay. We start with Steve Kaveri. Who coined the term hormone? Right. Anybody want to answer? There's not audience question, but still.
You got.
So this was by William Dennis and Ernst Starling. Ernst Starling is one of the most prolific person over the past, during his lifetime, 78 years. He gave 65 years of his life for endocrinology. And that is why all the citations in the most international journals, they revere him and he is respected quite a lot. Question number 2 is who is the father of endocrinology? King B. Sorry? King B. Sorry. Krishna. Who is the father of endocrinology? I think when we have told the historical round, these are questions that you should predict few questions. No? Apparently, I was told my questions are tougher. But looking at the first round, I think my questions are simpler. So Thomas Edison is often referred as the not Edison, not Thomas Alva Edison. He is Thomas Edison, who discovered Edison's disease, and the myself, this is named after him, is often referred to as the father of endocrinology for significant contributions to the field, especially in the work for his work on the adrenal glands. So Thomas Alva Edison discovered the bulb. So he is not this guy. Okay. So round three. Third question is: we all know the dogs are man's best friend and they are most faithful. So if I have to talk with respect to the role of a dog in terms of insulin, so these are the people of which two of them got the Nobel Prize for medicine in 1923 or 1924. So Batting and Best, I think they are the two people who have got the Nobel for medicine. So we all know of these people, but I want to know the name of the dog. Team Bima. One clue I will give. It is the name of one of the characters in a famous TV series called Game of Thrones. The name is Marjorie. The name of the dog is Marjorie. There are around 6 to 8 dogs who were involved in the process of making insulin. I think this dog survived after giving the extract of this dog's pancreas. The insulin was taken and given to Louis Thompson. He was the first person to receive that insulin. So that is the role of so they say that Frederick Banting and was awarded the Nobel Prize for Physiology in Medicine. Physiology of Medicine. It is reported that Banting loved dogs and it pained him deeply that his pre-human insulin trials were conducted on unsuspecting canines. Despite long hours and no salary, Banting said the dancers took very good care of the dogs. According to F. Sanskrit was no more, he is the consultant diabetes and endocrinology Bishop Hospital. During this period, the dogs were more than experimental animals. They became friends, and the dogs seemed to understand the importance of the experiment and were certainly, according to the history, most cooperative. So today, if anyone is taking insulin, I think we should be thankful to the dogs. Of course, that's writing and best. Again, another Nobel team Tungabhadra, who won the Nobel in Physiology in 1950 for discovering the role of iodine in hormone. Can I ask what have you read?
Yeah, but
Okay. To be honest, I also read it. So he is Edward C. Kendall. He is the Nobel Prize for Physiology in 1950. Okay, so since we are talking of diabetes in pregnancy, I think this should be, after looking at all the questions, I think this is the easiest one. Who is credited with pioneering the use of insulin therapy for pregnant women with diabetes? Apparently, many people. And you got the easiest one. Okay, the answer is Priscilla White. She was so this is how the classification has come as well. So at the end of the first round, only one question was answered after one more question is there. Okay, sorry. Oh, okay, sorry. When was the term hypertension coined by and by whom? When was the term hypertension first used and coined by whom? I was in Kenya for 2 years.
same and
And the answer is was first one was participated in Summer Slam in 1860. So then the first round, audience question. Yes. So this is the question from the OBG side. Anybody from the audience? She's one of the famous transgenders of the United States of America. She was the one who started the movement. Nobody's answering? Christine Jorgensen was an American trans woman who was the first person to become widely known in the United States for having a gender reassignment surgery. Okay, my question is very simple. Who developed the movement? Every day we check. Every day we check probably not less than 50 blood pressures postgraduates, not less. So if you are not a good postgraduate, if you are not checking 50 blood pressures per day. So who discovered that? Or who invented that stigma?
Anybody from the audience?
Samuel Carl Richard Bosch. He was the person who made that device. For all these 200 years we've been using. Oh, who answered? Okay.
Samuel.
Okay. Good.
Dr. Thakur. Dr. Thakur, medicine PG.
Yes.
Yes, sir. The score of the first round.
I think Tungabhadra is the only one who has opened their account. The rest of them are yet to open the account. Big round of applause to team Tungabhadra. Yes, nothing is lost. We are just beginning. So, Jaka.
Coming to the second round, these are direct question round. No option will be provided. 10 points for right answer and minus 5 points for wrong answer.
Puttan, if the answer wrong, minus 5.
And this question can be passed, but here the marks will be different. Minus 10 for wrong answer and plus 5 for right answer for pass.
So, just to make sure that you are going to answer when it is a pass question, because you will be if it is a direct question, it is a minus 5 for the wrong answer. But if team Kaveri is asked and team Krishna answers wrong, so then you will become minus 10. Okay, so you should be doubly sure when you are answering this question. Yes.
So the pass question will be for the immediate next team. If they pass, again for the next team, clockwise for the first player. Then it will be anti-clockwise. Coming to the first question for team Kaveri, testosterone is converted to dihydrotestosterone. This process is catalyzed by the enzyme.
Team Kaveri.
Pi-alpha reductase, right answer. Next question for team Krishna. Karyotyping in rare syndrome is? Don't murmur the answers, please.
I think these are straightforward questions. Turner syndrome is? This is not Turner.
Shall we pass the question to the next team?
Team Krishna, you want to take? Sorry, Team Bhima, want to take up? Tungabhadra? Yeah.
46 XY, right answer.
46 XY. Fantastic.
Plus 5 for Tungabhadra.
Plus 5 for Tungabhadra. Next
question is for Team Bhima. When does ovulation occur after LH search?
Simple straightforward question. When does ovulation occur after LH search?
32 to 36 hours. Wrong answer. Minus 5. Question for next team. 35 to 36 hours. Wrong.
Is that the same thing? Minus 10 for Tungabhadra.
Minus 10.
Minus 10 for Tungabhadra. Minus 5 for Bhima.
No, it is again minus.
Yeah, because it's a past question. Yeah.
Next,
When does ovulation occur after LH search?
Pass. Next team Sharavati, you want to answer?
Sharavati. Next is Kaveri. You want to answer? No, we were waiting. Sharavati, I just stopped. 24 hours.
You can give.
Can give 24 hours.
Okay. The answer is 14 to 26 hours.
Okay, so plus 5.
Plus 5.
Plus 5 for Sharavati.
For Sharavati.
Okay, next question is for
Next question is for fourth thing. Tungabhadra.
Tungabhadra.
Low dose aspirin as prophylaxis for prevention of preeclampsia is. What is the dose of the low dose aspirin for prevention of preeclampsia?
What is the dose?
Right answer.
Okay.
Right answer.
But we don't have an 81 milligram aspirin tablet.
Yeah,
So
the tablet available is 75.
75.
So you need to answer 75. That was the answer. Next question is for Team Godavari.
Tungabhadra plus set.
A 28-year-old woman was diagnosed with diabetes at 28 weeks and was started on insulin. What should be the target fasting blood sugar level? Right answer.
95. Okay. Team Godavari, good answer. Where is the home team support? Right. Next question.
The next question is for Team Sharavati. What is the categorical term used when the gender identity and or gender expression differs from what is typically associated with a designated gender? Be specific.
Transgender is an umbrella term. You have to be very specific. Gender expression differs from what is typically associated with the designated gender. Not the whole. What is this called? Team Kaveri? No, you don't have all the day. Team Kaveri? Team Krishna? Gender incongruence.
Right answer.
Right answer. So Team Krishna, that's plus 5.
Plus 5.
Correct, right? Plus 5, right?
Yes.
Yes, plus 5.
Over to you, sir.
Okay. Okay. I would, these are kind of cases where we usually are referred to see those cases in the wards. So that is I have compiled. Maybe a few of them are a little too much or too less, but let's see how it goes about. So Team Kaveri, antihypertensive therapy in severe hypertension with no eclampsia. I want the inpatient management. What is the rate at which you give IV fluids and the drugs that you use, IV drugs and dose to reduce hypertension in pregnancy with a BP of 160, 110 in the ICU. Team Kaveri. Team Kaveri, IV drugs and the rate of IV fluids that you are going to give in a hypertensive pregnant lady with a BP of 160, 110. One is levodopa, yes.
Starting is 20 milligram, maximum of 300 milligram. I used to have the rate of 40 to 50 ml.
IV fluids, how much?
Value come into that.
Okay, so before I go on to discuss the answer, your answer is right. Only if you answer both of them correctly. Okay, so I would not want to give that as an answer. Next, Team Krishna. Quite simple, regular case. This is not something very deep pathophysiology. Simple management. What are you going to do? This patient is right in front of you. What are you going to do? IV labetalol one next.
IV labetalol, we can give hydrogen also. And
okay, fine. IV fluids. Rate at which you can give IV fluids. You may give lesser, you may give more. That's not a question. At what rate you should be giving? 50 ml per hour. So negative marks, negative marks. Team Bima.
IV labetalol, IV hydrogen, methyl dopamine.
Methyl dopamine.
IV fluids normal saline 100 ml per hour.
Okay, I think we can consider this pretty close. It's around 80 ml per hour, so I think we can give the answer to TB. Good answer. So, okay. Okay, we'll discuss both of them. Next question also we'll discuss both of them the answer after the next question. Okay, so maximum. So this is for Team Krishna. What is the maximum dose of drugs commonly used in the management of hypertension in pregnancy? Full marks if at least 2 drug doses are answered correctly. So these are the drugs that we give. I want the doses of at least 2 drugs for you to get the right answer.
Maximum dose is 220 mg per day, 220 milligrams, sir.
So lapitalol 220 mg, that's what you are saying, and then
And also we give first we give 10 grams, 10 mg, sir. After that we can follow it by another 20 mg, so 30 mg maximum.
so lapitalol 220 mg, don't say all that. Lapitalol 220 mg, nifedipine how much maximum? 30 mg.
And
Either way, both answers are wrong. Next, Team Bhima.
ಮಾತಾಡೋರ್ನ ತೋಲತ್ತೀರಿ ಅಂದ್ರೆ ಆ ಕ್ಯಾಮ್ರಾದಾಗ ಇಲ್ಲಿ ಸ್ಟೇಜ್ ಮ್ಯಾಗ ಓಡಾಡ್ಲತ್ತಾರ
Lapitalol 220 mg. IV.
ಪೂರಾ ಹಿಂಗೆ ಪ್ಲಾಟ್ಫಾರ್ಮ್ ತುಂಬ ಓಡಾಡ್ಲತ್ತಾರ ಸರ್ ಅದು ಮೈಕ್ರೋಫೋನ್
I will disturb that answer.
ಇವ್ರದ್ದು ಎದರಿನವ್ರದ್ದು ತಗೋಬೇಕಾಗ್ತದೆ
Nifedipine is oral 50 mg.
Wrong answers. Tungabhadra.
ಸ್ಟೇಜ್ ತುಂಬ
Levotalol, IV
Taste.
maximum dose is 220
Yes.
mg and oral is 2400
Yes.
and methyl-dopa maximum dose is 4 grams.
Methyl-dopa 4 grams. Okay, nifedipine?
100 mg maximum.
ಹಾಂ
Yeah, I think I will not I will let some senior person. I'll show the reference for which I am talking. Let the senior person decide. So you can repeat your answer. I'll consider. I'll go to the next one. If they answer much more correctly, then yes. If not, we'll give it to you. So Tungabhadra, your answer is
Levotalol IV is 220 mg maximum. Oral is 2400 mg. Methyl-dopa maximum dose is 4 grams and nifedipine 100 mg.
okay. Godavari. So next time if I am on call, you are not calling. Okay. For this question, for this reference, you are not calling. Okay. Team Sharavati.
So labetalol IV is 220 milligrams, oral is 2400 milligrams, and nifedipine the maximum 60 milligrams.
Okay. Tungabhadra, can you repeat? 220.
IV levotalol 220 mg, oral 2400 mg, methyl-dopa 4 grams, nifedipine 100 mg.
Okay, fine. So Team Kaveri, wanna take up? Team Krishna, wanna take up? Bhima, wanna take up? No, right. So let's see the answer. Okay, this is from the Mayo Clinic, state-of-the-art diagnosis and treatment of hypertension in pregnancy. So, okay, so antihypertensive drugs for one when the BP is more than 160, and I did not ask everything, so I just put it properly. When the BP is 160 by 110, so the dose that you can give, that's what is written. I'll show you the next slide. This is from the Mayo Clinic state-of-the-art. Okay, so okay, yes. Methyl-dopa, you said how much? 4 grams. So the maximum dose is, even if I take 300 into 6 milligrams, so it's around 6000 milligrams. Lapitalol, how much you said? 2400 milligrams. So that's right. So nifedipine, you said 100. So I think somebody should decide whether we should be giving marks to whom in this. No, I mean even I am of the opinion, no, but somebody wants to be a little considerate and give marks.
ಹೌದ್ರಿ
All are in divided doses. So 2000 milligrams in divided doses. So they say 2400.
ಪಿನ್ ಹಚ್ಚಿದ್ದ ಸರ್
So they said 4 grams. Yes. So lapitalol is 2400 milligrams per day, and nifedipine is 120 milligrams per day.
ಮಾಡ್ಯಾರ ಸರ್
So I think none. Which two? So nifedipine you said 100, but it is 120. No, 20 to 120, right? That is maximum dose is 120. So 60 milligram PD. That's what you can give. So yeah, the consensus is nobody gets the right answer. Thank you. Yeah, fluid. Sorry. Fluid is there. Fluid management restrict the maximum to 80 ml per hour when there is an amylase in place. So name two for. So this is for second question. This is for Team Krishna. Correct, right? Am I missing the order? It is. This is for Team Bhima. Correct, right? So Team Bhima, name two positive effects of the use of metformin in PCOD.
For treating insulin resistance, and also it helps with weight loss. Some amount of weight loss management.
Some amount of weight loss. Okay. So insulin resistance and weight loss. Okay, we'll come back to your answer. Tungabhadra, Godavari, Sharavati, Kaveri, and Krishna. I think metformin, everybody should be knowing in and out about that, right from its basic pathophysiology or the basic mechanism of action till the adverse events. So in PCOS and in GDM, there are two important things. Sorry. So reduce risk of miscarriage, second line ovulation induction drug, and decreases the OHSS with IVF, and it has a mild anti-androgenic effect. So that is the reason why we would be using it in, because per se for insulin resistance, no, it helps, but no, per se for somebody if they are having insulin resistance, we will not give them metformin. So that is not the answer. So I don't think so. I think everybody will concur. I thought we will not be giving them one. But in GDM, reduced weights and safety and efficacy comparable to that of insulin, reduce risk of miscarriage and decrease the chance of hypoglycemia. Okay. Next question is Bhima. No, sorry, Tungabhadra. Sorry. Tungabhadra. What does the process of transitioning involve for some transgender individuals? What is transitioning? Godavari, Sharavati.
So it can be done through two things. One is through hormone replacement therapies like testosterone and estrogens, and the others is the surgical procedures they can undergo, vaginoplasty, phalloplasty, and
what does the process of transitioning involve for some transgender individuals? So you are saying surgical correction
and hormonal replacement therapy
and HRT, during HRT. Yes. Oh, fine. Anybody will wait for a better answer. If we get a better answer, then we'll probably see. Kaveri, Krishna. Okay. Aligning one's physical characteristics with their gender identity, which may include hormone therapy or gender affirming surgeries. Right answer. Okay, this is again medicine reference that usually comes to us. What are the tasks to be performed within the first 6 hours of the identification of severe sepsis? If at all you have clinically suspected sepsis, what are the first 6 hours? What are the tasks to be performed within the first 6 hours of the identification of severe sepsis? This can be done by either of the departments, both the departments, or individually. Godavari, I would not want to be on call when you are on duty. Sharavati,
So secure the airway, breathing, circulation by vasopressin cytofluids and appropriate drugs.
step first, step first. Okay.
So airway,
ABC.
ABC, the airway,
Okay,
breathing,
one is
circulation,
ABC, then
drugs.
what else?
So IV fluids to start with to maintain
Okay.
the hypovolemic status, and then vasopressins,
Vasopressin.
noradrenaline
Okay.
for blood pressure control, sir, and higher antibiotics. And then also to send for lab investigations, the septic biomarkers like procalcitonin, CRP,
Biomarkers.
yeah.
Okay.
And then observe the urine output and blood cultures. I mean, that is in the lab investigation blood cultures.
No, fine. We'll come back to the answer. We'll see. Keep Kavani.
Start with IV fluids, 30 ml per kg per hour, followed by start with empirical antibiotics.
What are the tasks to be performed within the first 6 hours of the identification of sepsis? Okay, I'm just so 30 ml per hour of 5 fluids, then
Start with empirical antibiotics and send within 1 hour send for blood
5
culture.
fluids, antibiotics, blood culture, then
Serum lactate level.
lactate level, yes. Okay, King Krishna, I want to improvise. You want to stay back and wait and watch. Answer.
IV fluids, antibiotic, oxygen, and hypertension management with ABC and urine output and input monitoring.
Okay. King Bhima, pass. King Padmabhadra.
First is airway breathing and circulation, and the serum lactate level should be sent immediately. And two lab bore IV cannulas and fluid management, sir. Next is IV broad spectrum antibiotics. If foci is available within 1 hour, sir. If not, preferably by 3 hours we have to start. And fourth one is before starting antibiotics, we have to send cultures and routine investigation to be sent.
Okay. So when you say routine, what do you mean?
Sir, CBC is a total count, LFT, RFT, and electrolytes.
Right. We'll see.
And also inflammatory markers, triseptin, procalcitonin, and ESR CRP levels.
Okay.
And cultures to be sent before starting the antibiotics, that is 3 hours.
Okay. So tasks to be performed within the first 6 hours of identification of severe sepsis. This is from the Surviving Sepsis Campaign Resuscitation Guidelines. Okay. So obtain blood cultures prior to antibiotic administration. Administer broad spectrum antibiotic within the 1 hour of recognition of severe sepsis. Measure serum lactate, and in the event of hypotension, with a lactate of more than 4 millimole per liter, and initial of 20 ml per kg of crystallite or an equivalent. Then apply vasopressin for hypotension that is not responding to the initial fluid resuscitation to maintain the MAP of more than 65. In the event of persistent hypotension, despite the resuscitation and with the lactate of more than 4 millimoles per liter, achieve put a central venous line and then make sure that it is maintained at more than 8 millimeters of mercury. Achieve a central venous oxygen saturation of more than 70% with mixed venous oxygen saturation of around 65%. So I think who should be given the answer? I leave it to the seniors. So Sharavati missed lactate, which is what we were looking into. Lactate, no, biomarkers, you said procalcitonin. I was specifically looking for lactate. Yeah, you said. Yes. So putting all together, I think Tungabhadra is the one we're going to get the point. This is another probably Diagnostic criteria, how do you diagnose? I think you guys are doing a fantastic job in probably diagnosing, so let's not go there. Okay, this is the antibiotic spectrum that is used in optic and gynecology. Uh, this slide should be put in all the optic ICUs so that they can pick and choose the right kind of antibiotic that can be used at that particular moment. Okay, so this is the last question for the round 2, correct? So, which international day is observed on November 20th to raise awareness is by the issues faced by the transgender individuals? Sharad. Kaveri. Krishna. Bhima. Tungabhadra and Godavari. The answer is International Day Against Homophobia, Transphobia and Biphobia. We are done with 2 rounds. Audience question. Okay. Audience question. Most commonest cause of, I think this is a straightforward answer, and if you do not get this, no consultants. First students and then consultants. Most common cause of amyloid and unit is, she answered, Anika, she answered, you should wait for somebody to tell that you answered. Okay, you will get one. CH, congenital adrenal hyperplasia is the answer. Okay, it's supposed to be one more question, no? Okay, we'll do that later. So round 3 is the starters of the visual round. It's a direct question. 10 points for the right answer, -5 for the wrong answer. Past questions again, -10 if you are answering it wrong and +5 if you are answering it rightly. So third question, we are still moving clockwise.
Start with team 1, Kaveri. The question is, what is the syndrome? Identify the syndrome in this photo and what disease it is specific for.
You have to answer both of them correctly, not only one. Team Kaveri. I think we started things late, so we will be moving along fast. Kaveri, you want to attempt? Team Kaveri, do you want to attempt? No. Krishna? Want to attempt? Sacral agencies?
Specific to over diabetes.
So, diabetes, we'll take it as diabetes. So, sacral agencies to diabetes. Okay, we'll wait for that.
Right.
We'll give it. Okay.
Anyone want to tell it?
Yeah,
Syndrome.
Yes.
Syndrome Gordon regression syndrome or sacral agenesis.
Okay, so when it is said, we'll give it to Team
Krishna.
Team Krishna.
Second question for Team Krishna. What concentration of serum magnesium concentration this reflex is lost?
At 10 to 12 milligrams per liter, it will be lost. At 10 milligrams per liter, it will be lost. And these kind of reflexes will be lost.
You want to tell in milligram per real or in milli equivalent? You have to be specific.
10 milli equivalent per day. Ten to 12.
Wrong.
Wrong answer. Team Bhima. You are attempting? 7 to 10 milliequivalents?
Right answer.
7
Or
to
if it is in the concentration, it is 9.6 to 12 milligrams per liter. Plus 5 for Bhima. Next question
Plus
is
five.
for Team Bhima. What is the condition identified and by
Simple,
what scoring
straightforward.
system it is graded?
Audience, please be quiet.
Okay. Now do we grade it?
Right
Very
answer.
good, let's go. Fantastic.
Plus 10 for Team Bhima. Next question for Team Tungabhadra. What is the condition identified and antenatal administration of
Both.
which drug causes this condition?
Pass. One attempt or no? What attempt? Godavari? Nothing was on, no pressure activities. I think is the right answer.
Right. Next question is for Team Godavari. Identify who is in the picture.
I follow her on Instagram. Who is she? No, she's from Manipal.
She is related to our fraternity.
She's from Manipal.
You can see she's wearing a shirt. We'll pass the question.
Since it is question, since the topic is what it is, you should be identified. Let's wait for your turn. Your turn. Your question. Transgender, why name the person? You should. Team Kaveri. Anybody attempting? Krishna, Bhima, Tungabhadra.
Answer is Dr. Trinetra Haldar Bumaraj. She's first trans woman doctor in Karnataka. Next question is for Team Saravati. Identify the technique in the picture.
Direct question.
You should be specific. I guess it is broad term.
Audience, please. Let's do the
No,
cooperation.
no, no, no.
Wait.
This has to be passed. Please, don't let the answer.
You know, Viva is always important. What to answer, when to answer. In Kaveri?
60, sir. Intracytoplasmic is right answer. +5. Over to you.
Yes. So it is see. Okay. So this is identify the candidate, 17-year-old girl with hearing loss and secondary amenorrhea. Kaveri, right? Team Kaveri, yes. Wanna attempt? 17-year-old girl with secondary amenorrhea and hearing loss. Krishna, Bhima, Tungabhadra, Godavari. Wanna attempt? Cartesian syndrome, wrong answer. I'm telling you not to identify the syndrome, I'm telling you to identify the karyotype. So, Sharavati, no. Simulated culture GTG banding, which is an abnormality, 45X. 17-year-old girl, amenorrhea, hearing loss. What is the first thing that will come? There is absence of one sex chromosome suggests of monosomy X in 55% of cells, the remaining 45% cells are normal character. The character will suggest a female with mosaic Turner syndrome. Mosaic Turner syndrome. Okay, so next question is for Team Krishna. So 59-year-old, we have discussed premenopausal hirsutism. So let me discuss your postmenopausal hirsutism. You could identify Simon Galvez score. This lady Simon Galvez score was 24. Give 3 differential diagnoses. That is a lab. So patient is having loss of there is androgenic alopecia, there is excess hirsutism, and then there is clitoromegaly. Name 3 differential diagnoses. This case is very, very interesting. Apparently, one of my senior professors told me that this is once in a lifetime diagnosis. Hardly less than 100 reported cases worldwide. I was happy to have got this lady operated here in BTGH. So the surgeon was Dr. Vasundhara Patil. He is busy as an examiner there. So we did a oophorectomy, bilateral oophorectomy without the ovary showing any tumor. Testosterone is sky high. Okay, anybody attempting? Anybody attempting? Three differential diagnosis for postmenopausal hirsutism. Okay, so the answer is bilateral radical tumor of the ovary, which was operated here only, and which we were able to publish it in the Indian Journal of Obstetrics and Gynecology. So identify the lesions and name three differential diagnosis. This is Steve for team Rima. Name three conditions with this disease and name first identify the lesion, grade it, and then identify give three differential diagnoses.
Acanthosis nigricans.
Nigricans, good.
Acanthosis PCOS.
Okay.
OHSS and what obesity.
Obesity is not a disease.
What diabetes conditions. Hyperandrogenic states.
Is that PCOD, no? Okay. Team Tungabhadra.
Acanthosis nigricans, causes of PCOS, diabetes mellitus, adenocarcinoma of the stomach.
Adenocarcinoma of the
Stomach. Gastrointestinal tumors.
I am not very sure of that one. The first two I will probably agree. But adenocarcinoma of the stomach giving rise to acanthosis nigricans. Dr. Gayatri, anything? Yes, will you it? Okay.
Type 2 diabetes, metabolic syndrome.
Yeah. Okay. I think the answer goes to Team Tungabhadra. Second, the acanthosis nigricans. This is grade 4. We have 4 grades: grade 1, grade 2, grade 3, and grade 4. This is grade 4. Velvety, like skin appearance, or on the neck, axilla, groin, all the flexural folds of the body. So this is we get this. Okay. Diagnosis: 7 years, 6 months, presented with the bleeding baby, delayed bone age, usually showing multiple abscesses on the ovaries. She is 7 years with multiple abscesses in the ovaries, short stature. This is for Team Tungabhadra. Direct question.
McCune-Albright syndrome.
Wrong answer. Godavari. Part of that McCune-Albright you may get there, but no. Team Godavari. We presented this as a poster in one of the conferences. Sharavati. No, specific diagnosis, no. Because the puberty is like your iron fever, n number of causes of fever. Because the puberty is very. Next, Kaveri, negative for them. Kaveri, Krishna, Bhima. Answer is Gandhi-Grumbach syndrome. We were able to publish this again in one of the prominent journals. We had three such cases. So round 3, this is for Team Godavari. 21-year-old female, first pregnancy, in 8 weeks. There is no hyperthyroid symptoms. This is the report. This is like just 2 days back I seen nobody. The TSH is suppressed and T4 is 18.4. Above the upper normal reference range. Godavari, answering. If not diagnosis, at least differential diagnosis. Team Sharavati. You are not able to see? No? Yeah.
Screen.
Hypothyroidism. Hyperthyroid. Differential hyperthyroidism is umbrella term. You have to be specific. Wrong answer. Negative for them. Kaveri?
Gestational
Gestational
hypothyroidism.
hyperthyroidism.
She don't have any thyroid features, sir, and it is just in first trimester, just physiological imbalance.
Right answer. This is gestational hyperthyroidism of pregnancy, or probably because of the HCG that the TSH is suppressed. Doing this? No, I'm doing this and that stuff is coming. Go on. Okay, so next question is that is gestational thyroidosis. So usually we do not treat till normally what happens is the TSH is suppressed in the first 8 to 12 weeks of gestation and then it improves over a period of time. So no need of treatment, she is not having any hypothyroidism. So team Sharavati identify the 3 clinical features and diagnosis. You have 3 features, 3 clinical features and diagnosis. Sharavati answering? No. Kaveri? Krishna? Answering? Others say yes or no? Bhima?
Preterm delivery
Preterm delivery.
because of fun.
Wrong answer. Tungabhadra? You're answering? Godavari? Huh? Feminism, huh? Clinical features in the photograph show Turner syndrome. So feminism is wrong answer. -5 for Godavari. So 3 things that they are seeing: bilateral fetal edema, blood neck and -10. Sorry, -10. Some bias. Bilateral fetal edema, blood neck and white space nipples. What is the question? Please raise your hand when we say answer. Please answer.
Postgraduates, undergraduates.
Identify what is the rule of 4.
4 sides, 4 mm and 40 watt.
Who is answering?
Please stand up.
No, who answers? You, our participant answers. Oh, you can give her a pen also. Yeah, give her. Anyway, she's participating. 4 punches per hour each for, I don't know what it is, but yeah, for 40 seconds. Delivery 640 joules of energy per hour. Okay, identify this disease and name the investigation of choice. Audience, raise your hand. Wait. You have to
Raise
answer.
your hand, don't answer.
Yes. Yes, left side. Yes, you can stand and answer. Investigation of choice. Yes, this is alright. Investigation of choice of this condition.
Anybody?
No, for this, you usually do a CT eyes to see the how much is your muscle development. So nobody gets it. It is gets TAO, thyroid associated ophthalmopathy, and investigation of choice is CT orbit.
Investigation of choice is CT orbit.
We will be going anti-clockwise now.
There are multiple choice questions. The rules are it is direct question, no pass question, plus and for right and plus -5 for wrong answer. We start from Team Sharavati. The question for Team Sharavati. A male patient presents with bicep scrotum, hypospadiasis with testis and well-developed breast. What is the likely diagnosis? Option A, Turner syndrome, B, Kalman syndrome, C, Klinefelter syndrome, D, Dickinson syndrome. Answer is Dickinson syndrome, a heterogeneous group of androgen deficiency syndrome due to X-linked recessive androgen receptor defect. Next question is for Team Godavari. Drug which causes hirsutism is A, methyl dopa, B, estrogen, C, thiopental sodium, D, all the above. Wrong answer. Correct answer is methyl dopa, as it causes moderate hyperprolactinemia. Methyl dopa, as it causes moderate hyperprolactinemia by inhibiting the enzyme aromatic 1-amino acid decarboxylase, which is responsible for the conversion of 1-dopa to dopamine. Next question is for Team Tungabhadra. An embryo with more than 16 blastomeres formed due to in vitro fertilization is transferred to option A, uterus, option B, fallopian tube, option C, embryo, option D, cervix. Uterus, conduction is right answer. Next question is for Bhima. Which type of eclampsia has worse prognosis? Option A, antepartum eclampsia, option B, postpartum eclampsia, option C, imminent eclampsia, option D, intrapartum eclampsia.
Option A, antepartum eclampsia.
Wrong answer. Right answer is postpartum eclampsia. Next question is for Christine Krishna. All of the above are pregnancy-specific scoring systems for maternal sepsis, except option A, MOEWS, option B, SOS, option C, OMSOSA, option D, MOSS. All are the scoring systems except don't know. The answer is MOSS. Round 4. Last question is for Team Kaveri. Which of the following is true about lochia? Option A, rubra serosa alba. Option B, rubra alba serosa. Option C, serosa alba rubra. Option D, lochia alba serosa and rubra. You should tell the correct order. Rubra alba serosa. Wrong answer. -5. There is no password. If you want, you can answer out of interest. Yeah, right answer is rubra serosa.
Okay. We are running out of time, so we are moving a little fast. So this is for Team Sharavati. 29-year-old referred from the antenatal clinic. She had been labeled as having gestational diabetes. Mother is type 2 diabetic. Her BMI is 23. OGTT is showing this reading. In the pregnancy, she had been treated with basal insulin to control her fasting hyperglycemia. She had not required insulin during the post-delivery phase. So, which of according is the most likely diagnosis? It's very, very important for us to understand that diabetes that comes in pregnancy can be so many things, because that will decide what the future course of action will be. So, which of the following is most likely diagnosis based on clinical profile? Medium, LADA, monogenic, type 1, type 2. Audience, please. Medium, LADA, monogenic diabetes, type 1. Right answer is the one with correct explanation. So, just not answering the answer, you will have to give an explanation also for it. Okay. Type 1 is wrong. Next, Kaveri. No password, sorry. So it is MODI. This is a GCK mutation which is associated with alpha glucose sensing in the pancreatic beta cells. So basically, these are the kind of people who will respond to a very small dose of OHS in future, and they may or may not require insulin later in life. So second question is for team Kaveri. Okay, Godavari, sorry. For team Godavari, 26-year-old man with a background history of type 1 diabetes, keen to know the risk of his offspring developing diabetes. He is a type 1, he wants to get married and have children. He wants to know what is the risk of his children having type 1 diabetes. His wife does not have diabetes or is neither pre-diabetes. What is the risk of developing type 1 diabetes for the baby born to father with type 1 diabetes? Correct? 5%. We will come back to that. Move fast. So the answer 5%. You want to know the options, but you said 5%. You take this as a direct question only. No, the answer is around 0.4%. The risk of developing type 1 diabetes is around 1-2% for babies born to mothers with type 1. The risk increases to 3-6% if the father of the baby has around type 1 DM. The risk is 5-6% if a sibling has type 1 diabetes, while the compounding rate of developing type 1 is around 50%. Next question is for Tungabhadra. 33-year-old Caucasian woman with revealed with a routine antenatal checkup when she was 16 weeks pregnant. It was her second pregnancy. Birth weight of her first baby was 4.1 kg. She has a family history of type 1 in her grandmother. Her BMI is 26.5. According to the NICE guidelines for the management of diabetes in pregnancy, the presence of which of the following factors should act as a trigger to screen for GDM?
GDM during the first pregnancy?
Okay, we will discuss. According to the NICE guidelines, the following have been the independent risk factor for development of GDM and thus any of the following should trigger the screening. So now answer is wrong. BMI of more than 30, family history. GDM during first pregnancy. That's what I said. Okay, I thought you said birth weight. Okay. So right answer. Furkan, right answer. So team Bima, according to the NICE guidelines, the following have been shown. Okay. Okay. Which one of the following is the most appropriate management option for menstrual children? Something wrong with the question. Okay, no, this is the next question. So this is for Team Bima. Okay, so a lady coming with a history of a 26-year-old lady coming with history of PCOD and hirsutism. What is the which of the following is the appropriate management option for a menstrual irregularity? PCOD and hirsutism. PCOD, hirsutism, irregular menses or oligomenorrhea. So what is the third choice? Okay, sir.
Option A, cyclopironicin.
Cyclopironicin. No, the combination is the answer is OTC. Wrong answer. Furkan. 25-year-old man was reviewed in the electron clinic for further evaluation of his infertility. He had a background history of bronchiectasis, dextrocardia, BMI of 22, clubbing, bilateral force suppression at the basis of the lung, scanty body hair, and facial hair with gynecomastia. Seminosis is 30 ml, 30 million per ml. Motility around 5%, 10% are normal. For T. Krishna, which of carcinoid syndrome? Yeah. Which of the following treatment plans is most likely to be successful in dealing with infertility in this context? Carcinoid is not a question that we are going to ask. Sorry? ICSI. ICSI is the right answer. In Kaveri, a couple in their early 30s were reviewed in the infertility clinic, married for 5 years. She has failed to conceive. On examination, BMI of the husband is 23 with a normal secondary sexual character and a testis volume of more than 10. What percentage of infertility is believed to be due to male partner factors? It takes 2 to tango, so if you are just investigating the female and leaving the male alone, it becomes difficult. What percentage of infertility is believed to be due to male factor? Less than 5%, 10 to 15%, 20 to 25%, or 40 to 45%, or more than 50%? Both
40 to 45.
30 to 35%. No, that option is not there.
40 to 45.
40 to 45. Answer D. What is the guess? Answer is right. What is the guess? No, because father. Okay. Right. The 40 to 45, that basically means roughly around out of 2 infertilities, for 1 infertility, the male is responsible. So, audience question? Yes, this is partially came. Our CDs are raising hand. So, is it the right answer? Okay.
Dr. Sushma, OBGTV.
Okay, then the audience question. Okay, why did I add this? I'm thinking now. Anybody wants to answer? Return with your correction regarding the TPO status to aim to maintain a TSH in the lower half of the first trimester. Right. So we are done with the equal rounds, I mean both the combined rounds. And we will directly go for the next round, which is interpretation of function test. I will try to finish as soon as possible. I know the patience is getting off. So direct question, 10 marks for the right answer, -5 for the wrong answer, no pass question. Okay? These are short and sweet. We'll move fast. Okay? We'll start with Sharafti. 23-year-old female with PPH post delivery, unable to lactate post delivery, comes with fatigue, weakness, and tiredness 3 years post delivery. TSH is 4.2, T3 is 35, and T4 is 2.3. Diagnosis? Steve Sharafi. Sharafi syndrome is the answer. The wrong answer. Sharafi syndrome. Next question for Team Godavari. 24-year female, no medical history, currently 8 weeks of gestation, TSH 5.6. Strongly positive anti-TPO. Diagnosis, Vidofilter or no? 5.6 anti-TPO positive, 8 weeks pregnant. Diagnosis is not Hashimoto's. Etiology is Hashimoto's. specific. Okay, wrong. Diagnosis, will you treat or no? Clinical, you treat, right answer. So this is the diagnosis algorithm for management of hypothyroidism. Tungabhadra, 3-year-old baby, jaundice on day 2, healthy mother with no extra parameters, TSH is 0.5, FT4 is 1.8, this is the upper normal reference range, TSH is slightly on the higher side, considering a normal individual, but for a 3-day unit, the TSH reference changes. So what is the diagnosis? Will you treat or not? Tungabhadra, you are answering. 3-day-old baby with TSH of 11, what is the diagnosis? Will you treat or not?
Neonatal hypothyroidism, and we should treat. It is on the day 6.
Normal child, no need to treat. If needed, repeat test based on the clinical features at a later date and then reassess. Because the TSH changes on day 3, the TSH reference range would be around 1.1 to 17. So it is normal. Okay? So TSH of 11 is not congenital hypothyroidism on day 3 unless it is clinical suspected. Okay? Question number 4 for Dima, 27-year female with 27-year female, DIPD, 4 years of levothyroxine usage for 7 days. She is pregnant now TSH is 2.5. What will you do next? Increase the dose, decrease the dose, or stop it before? TSH is normal. Team Dima? Team Dima answering or no?
Will increase the dose.
Increase. How much will increase?
30 to 50%. 30%.
So the dose pregnancy confirmed, increase the dose by 30 to 50%. Question number 5 is to Team Krishna. 30-year-old, 12 weeks pregnancy, vomiting more than 15 times per day, epigastric pain at 10th week, nausea, dizziness, lethargy, pulse is 108, BP is 160, FT4 is elevated, TSH is suppressed. Diagnosis. Elevated FT4, TSH is suppressed, 12th week of pregnancy with symptoms of upper GI symptoms. Krishna answering? Okay, no answer. The answer is hyperemesis gravidarum and gestational transient thyroidotoxicity. Last question. Being a 29-year-old female, being worked up for infertility, has galactoria, denies any PPI or lopridone or Lexinara use. TSH is 76, prolactin is 74, which is significantly elevated. What do you do next? MRI to look for a prolactinoma, start cabergoline, tell her to wait for 1 year before conceiving, start LT4 and start cabergoline, then as above. So whenever we see an abnormal report, the gist is to go for the treatment. What would you do? Prolactin is 74, TSH is 76. Both are high.
Start levothyroxine and start cabergoline.
Start levothyroxine and start cabergoline. Yes, the commonest mistake that is made. That is the wrong answer. You don't give cabergoline for such a situation because you treat hypothyroidism, the prolactin will come down by itself. So this is the pathophysiology. If we have time, we would have gone into it. So TSH is prolactin is elevated when TSH is elevated. Even subclinical hypothyroidism can also cause elevation in prolactin. So do not treat elevated prolactin when TSH is elevated. Rapid fire. So last round we are rushing a bit because we have a talk to go. So
Okay, beginning with the rapid fire round. We'll begin with Team Sharavati first. So the rules are Clear? Direct question, plus 10 for right answer, no negative points, no pass question. 10 questions per team, you get 100 seconds to answer the 10 questions. So, answer accordingly. So, beginning, Team Sharavati, the scorer, please be ready. What is the ultrasonography finding to diagnose polycystic appearing ovaries to define PCOS? Diagnostic, ultrasonography finding. No. Okay, next question. What is the drug of choice in controlling blood pressure in severe preeclampsia? Yeah, right. What is three-parent IVF?
Yeah, 1 minute left.
Ovum and the sperm is taken from different individual and
No. No. GFR is increased in preeclampsia. True or false?
False.
Yeah, right. First line of drug for ovulation induction in a woman with polycystic ovarian syndrome.
Sir.
Letrozole.
Yeah, right. What is azoospermia? Yeah, right. No sperm in the cell. Best test for fetal lung maturity in a diabetic mother is?
10 seconds, sir.
Visceral fat is metabolically more active than subcutaneous fat in patients with PCOS. True or false?
Time up.
You can answer this question.
Time up.
False. No. Wrong answer.
Time up.
Next, start. Next team.
One second. Wait.
First time, wait.
Yes.
Okay. Team Godavari, time starts now. Your question is fetal starts secreting insulin by what gestational age? Wrong. What is Miller-Woodruff test? In normal pregnancy, remodeling of spinal arteries begins at? Yeah, right. Recommended daily allowance of iodine in adult is 150, right? The probability that a cycle will result in a pregnancy is called? Yeah, fecundability, right. What is the other name for sinusitis infertility syndrome?
45 seconds, sir.
Wrong. Clitoromegaly is defined when the size of the clitoris is more than? Wrong. It's
30 seconds,
1
sir.
centimeter. What is normal waist hip ratio in a woman? ACE inhibitors are contraindicated in pregnancy, true or false? Yeah, right. 20% of recurrence of GDM after first pregnancy. Percentage of recurrence of GDM after first pregnancy is? Yes.
Time up.
Time up. Next team, Team Tungabhadra. Your time starts now. In HELP syndrome, LP stands for? Yeah, right. What is the percentage reduction of dose of L-thyroxine after delivery? 20%? No. Gonad are bipotential till what gestational age? 7 weeks. Yeah, end of 6 weeks. I'll give it to you. Hypocalcemia in newborn is defined as a severe calcium. Yes. Yes, repeat your answer. 7 milligram per day. No. According to Ferryman-Callaway classification, hirsutism is diagnosed when the score is more than 8. Yeah, right. The dose of chlomiphen citrate in chlomiphen citrate challenge test is 50 milligrams. Wrong. Target HbA1c in patients with gestational diabetes is lesser than 6. Less than 6. Wrong. First answer is checking. Smoking causes an increased risk of preeclampsia. True or false? You have time, you can think and write. Answer. What? False. Yeah, correct. According to WHO, the minimum normal sperm count is 39 million. Wrong. What is the most common cause of autoimmune hyperthyroidism in pregnancy? Yeah, right. Your 10 questions are over.
Okay, the next faster. Pretty good. Next thing, Nima. Time starts now.
Your time starts now. An 18-year-old man has obesity, oligomenorrhea, hirsutism. The most probable diagnosis is
PCOS.
right. The secretion of FSH in men is inhibited by negative feedback effect of
Inhibin.
yeah, right. SRY gene is located on
Chromosome 6.
wrong. What is the minimum cutoff for defining proteinuria in a random urine sample in preeclampsia?
0.3 gram per day.
Yeah, right. Class 1 A1 of bacilloid classification management is by
Diet restriction.
yeah, right. Acanthosis negligence is a sign of PCOS is due to
Insulin resistance.
better answer.
Patient due to hyperandrogenism.
No. Electrolyte imbalance seen in OHSs is
Hypomagnesemia, hypocalcemia.
no. What is the mortality rate in a thyroid storm?
20.
I'll give it to you. Evidence of microangiopathic hemolysis is diagnosed by which lab investigation? 8 seconds.
Time up.
Okay.
Krishna.
Team Krishna set.
Come.
Okay, your time starts now. An antral follicle count of less than 4 poor response, true or false? Yeah, right. The first sign of puberty in a girl is wrong. Normal leukocyte level in semen is
Less than 1 million.
yeah, right. Ovaries develop from
Ectoderm.
wrong. Documentation of elevated serum LH-FSH ratio is required for diagnosis of PCOS. True or false? False. Yeah, right. Gold standard investigation to detect tubal patency is yeah, right. In low ovarian reserve, the level of anti-Mullerian hormone is less than 1. Yeah, right. Percentage of PCOS patients having diabetes mellitus?
False.
15%. No, wrong. Pregnancy is a diabetogenic state. True or false? True. Yeah, right. According to WHO, macrosomia has birth rate of more than
4.
yeah, right. More than 4 kids. Finish your 10 questions and we finished it quite fast.
Last set of questions for Ms. Kaveri.
Okay, we'll begin. Press is preeclampsia. In preeclampsia or eclampsia stands for progressive reversible encephalopathy. What? Progressive reversible encephalopathy syndrome. No. Posterior reversible encephalopathy. No, I'll not give it to you. Newer predictors of PIH. SFLT1 is reduced. True or false? False. Yeah, right. Risk of developing type 2 diabetes mellitus within 15 years of GDM is 50%. Yeah, right. Cytokine involved in ovarian hyperstimulation syndrome is
Interleukin 18, tumor necrosis factor,
interleukin
18.
no. Preferred method of cryopreservation of sperm. Histosalpingography reveals bead-like fallopian tube and clubbing of ampulla. Most likely diagnosis is
Genital tuberculosis.
yeah, very good. At what gestation age the pregnancy should be terminated in patients with GDM with well controlled on insulin?
39 completed.
Yeah, good. Corpus luteum produces progesterone and what other hormone? 20 seconds.
HCG.
No. The diagnostic of premature ovarian failure is FSH more than dash international per liter before the age of 40. Last 8 seconds.
More than 10.
No. HOMA IRs in PCOS stands for
Insulin resistance.
time up. Okay, till the scorer finalizes the scores, I would like to thank our Dean, Dr. S.M. Patil sir, Vice Dean Madam, Dr. Anuradha Patil ma'am, and Raiko Patil sir for giving us, and Dr. Pujari sir for giving us all the facilities to do the audiovisual system, auditorium and everything. I would like to thank all the HODs, Dr. Sujata Gadel ma'am, Dr. Anish ma'am, Dr. Usha Dodmani ma'am, and Dr. Nita Harwal ma'am. Also the medicine HODs, Dr. Chandrakala ma'am, Dr. Hamad sir, Dr. Dodmani sir, and Dr. Bharat Kohli sir. A big round of applause to Team OBG from MRNC. Please, I got a lot of support, patience, and to bring up the whole of the quiz for today's function, it goes to the whole of the Department of OBG from MRNC. Special thanks to our HOD Dr. Nita Harwal ma'am for providing the projector and table, chairs, everything, despite of the fact that exams are going on. And special thanks to Dr. Maladi ma'am, Dr. Manata ma'am for finalizing the quiz questions and guiding me to complete the whole of the event. Definitely Dr. Swaraj sir for because I pulled him in the quiz competition and I made it work for almost 15 days. Thank you, sir. Thank you. A big round of applause for all the postgraduates. Well done. You have performed very well. I hope we were not short of hospitality from Maria Karnatakanews Medical College. If the scores are out, I request Dr. Swaraj sir.
We will announce the results in another half an hour or so. You can take a seat in the first row. Please don't leave the first row empty. I think everybody was waiting for the stock to come now. So we just the quiz overshot by half an hour. Sorry for that. Now I think it's time that we talk with the top. I think it's time for us to talk on the talk that we all came for. I'd like to invite Dr. Gayatri to come on the dais and talk about transgender in health and disease.
ಇದು ರೆಕಾರ್ಡಿಂಗ್ ಮಾಡ್ಲತ್ತೀರಿ ಆಡಿಯೋ ರೆಕಾರ್ಡಿಂಗ್ ಎಲ್ಲ
On the dignitaries of MRND, API Gulbarga, and Foxy Gulbarga, and the coordinator Dr. Saras sir. A very good morning to all of you, and thank you so much for having me here today. So I shall discuss approach to transgender persons today. I think at least the PGs have come prepared a little regarding transgender, but because we have the gynecology department and people from Foxy, whenever there's a child born and you do not know the sex of the child, basically how do we determine the sex of any child who is born? We look at the external genitalia. Yeah, we look at the external genitalia. And if you cannot say, depending on the external genitalia, what the sex of the child is, what would you do? Can you name what is, can anyone, any gynae PG, name probably medicine PGs might not be knowing, what is this which I have displayed there? This grading, the staging which I have put now, what staging is this? We have, when there is any genital ambiguity, we have two types of scoring systems. One is for a female with genital ambiguity and the other is for the male. For the male, we have something called the external masculinization score. So for male, depending on how the descent of the testis is, depending on the length of the phallus, depending on the labioscrotal fusion, and depending on the position of the opening, we classify the genital ambiguity. And this which you have seen here, this is like Sarasa today asked so many questions in the quiz. Some of them were the questions which were actually asked in the DM endocrinology entrance exam. This was one of the questions. This is called the Prader staging. Okay. And that Marjorie, that dog also, that is something important that was asked. So this staging, when you look, we have one which is normal. The first is normal female genitalia, and then you have 1, 2, 3, 4, 5. So then, like we mentioned that during the quiz this was discussed that the bipotential gonad, the gonad is bipotential till the first 6 weeks. And then when is it that what is the sex of the child is determined the explicit sex, the biological sex. What is biological sex basically? So what chromosomal sex is what is determined by karyotyping. Biological sex is usually what we say depending on the external and internal genitalia, but this is an obsolete term now. It is better not to use this, but generally when you name someone as male or female, we do it depending on the external genitalia, right? So this is something which is finalized after the 13th week. Okay, between the 6th and the 7th week, you have, this is where you decide whether the Mullerian structures develop, whether the Wolfram structures develop, whether the child becomes a male or a female, and this is when testosterone has its effect on the sex of the child. Okay, so after this, so like we had a case which was discussed where it was mentioned that there is a very rare case which sir had discussed where the modified Feriman Galloway score was very high. So in this patient which sir had mentioned, had we looked at the external genitalia, what are features of virilization do we expect to see? Can any of the direct PGs answer? What features? Yeah, gynecology PG. I'm so proud of you. You answered questions with general medicine people didn't answer from the general medicine side. Yeah. So what is it that you see?
When we talk of virilization, what is the difference between hirsutism and virilization? Okay, so what do you see? Please visit it. Please visit it. Good, good, good. So the thing is clitoromegaly. Clitoromegaly is the only thing, only sign of virilization which you see beyond the 13th week for the fetus. Okay. The other thing which she mentioned, which was a term which we did not use till we came into DM, I'm very glad that she has used it at the MD level, is about posterior labial fusion. Posterior labial fusion is something which happens when there is exposure to testosterone in the fetus between the 6th and the 12th week. So that is when we go to Prader stage 2. Before that, irrespective of the testosterone levels, the maximum level of virilization seen is at the level of stage 1, only clitoromegaly. So we would look at something called clitoral index. We would look at the length of the clitoris and the width of the clitoris, and we would calculate length in mm into width in mm. And the clitoral index of more than 35 indicates clitoromegaly. So that is stage 1. Then stage 2 is posterior labial fusion. Stage 3 is a single orifice. So whenever you have a baby, with stage 1, you will still name the child as a female. When you have a baby at stage 2, again posterior labial fusion, you have something called the anogenital ratio which you calculate, by which you determine the posterior labial fusion. But again, you will call the child a female child. But at stage 3, here there is ambiguity. Stage 4 and 5 are more like a male. But when you see a single orifice is seen in a male. In female, we have two different openings. Okay, so this is where the problem comes. So then, so when you have a child, like we mentioned, which is the most common cause of genital ambiguity? This was asked in the quiz. Congenital adrenal hyperplasia. So what is the problem with congenital adrenal hyperplasia? If you have the commonest thing, if you have 21 hydroxyl deficiency, when you have this, how is the child present? Are we bothered at that point of time when a child with classic CH presents to you? What is classic and classic CH? Yes, electrolyte imbalance. The child presents in shock. So when the gynae PG is tested by the patient attendant to answer what the sex of the child is, whether the child is a male or a female, you tell them, I have to save this child first because the child is in shock at that point of time. Okay, saving the life of the child is important. That is how you buy time, and once you buy time, you will go for the investigations and then determine what the cause is. And usually, if the level of androgenization is already to a greater extent, you will rear the child as a male. If it is less, it is better to rear the child as a female. And in general, it is easier to make, I mean, whenever people go for transgender surgeries or in general, it is easier to develop a new phallic structure is something which is difficult. So it is always easier to rear a child as a female child, to make a male child a female child, and to make a female child a male child. This is initially when the parents have liberty, or if you are given an option. If you are given an option, but then as the child grows, the child starts developing feelings. The child then decides the gender identity. What we assign is something we assign at birth. So this is called gender break. Okay. So this is sex depending on the genitalia we describe. Then the child gradually develops a gender identity. Gender identity is something the child develops depending on the androgen exposure of the child all through the child's childhood, the child's androgen exposure. Okay. So there might be children who, just for an example, when they get to know the sex of the child, that the child is a female, then they go to some quacks and ask to do something to make sure that the child born is a male child, so they can be exposed to androgens. Then we have something called endocrine disruptors, environmental pollutants. So they say that children born with genital ambiguity, this in general is increasing. Transgender, it is not that the prevalence is increasing. Probably people have now more liberty to come out, or they no longer conform to the societal norms. Um, so then, this gender identity is something which the child thinks, which is the child's brain identifies. See, I am a male, I am a female, irrespective of the stamping that the parents have done. Then how the child expresses himself or herself. Like during childhood, most male children also, when they see their sisters wearing bangles, when they see their sisters wearing a bindi, they are also interested in doing that. So this is how the child expresses. It could just be for fun. So then gradually we will. This is why we don't take any decisions in haste before the age of 16 years. We don't start any kind of therapy which is gender affirming. Okay, we can stop the puberty and let the child come out with a conclusion, but we won't start any specific therapy before the age of 16 years because the child himself or herself might not have come to a conclusion. And then we have something called gender fluidity. कभी लगा I'm a male, sometimes I felt I'm a female. So and then we have to be as doctors again. At least we have to be legally safe as well. So we have to wait till the age of 16. Till then, the child would gradually develop a style. The child would express. The child would have developed some voice, a particular voice. Voice is depending on the size of the Adam's apple. But then the way the patient talks, the patient can have a masculine voice, but might want to talk in a feminine way. Okay, so how the patient expresses himself or herself, or they, for that matter, now we have a number of pronouns. So how they express themselves through their voice, through their mannerisms, through their way of dressing. This is all expression. And then attraction is inclination towards whichever sex they are inclined to. So yeah. So we have something called designated gender, and then we have incongruence where they don't identify with the gender which is assigned to them at birth. And identity, again, this is their internal sense. So they may say that they want to be addressed as male or female, or sometimes they might mentally be gender fluid. So they might not want to be addressed with a particular name of a particular gender. So nowadays we have these terms called they, they, zai, all these things. Or we have something called hir. So his ka H and I, and then her ka R E R na. So here is one term which they want to be which they want that they be used to be called, the term through which they want to be called. So you have these different neopronouns. These are terms called neopronouns. This is how they want to be called. Transgender. So transgender is in general a vague term. It refers to identity where the identity differs from the gender assigned at birth. So they could be agender. They might say they are a male or a female. So this is cisgender, where you specifically say that they are male or female. Or in transgender, you have the whole spectrum, where they can say that they are agender, bigender, pangender, because you have a third gender. So pan, non merely bi, or pangender, gender fluid. Again, they can be at any point of time. So gender fluid or gender queer, non-binary. You might just say that they are non-binary. And if because of this they experience any kind of mental distress, it is called gender dysphoria. Again, orientation is what we refer to as LGBT. So they could be gynephilic, androphilic, bisexual, asexual, queer. Queer is just not according to the normal norms, different from the normal. Expression we mentioned, the kind of the way they express they want, in that way they want to have their role in the society. So inclination, they could be either inclined to females, lesbian, inclined to males, gay, bisexual, transgender, queer, intersex. Intersex is something which we determine at the time of when we designate a sex. That is when we determine whether they are intersex or not. And at that point of time, we might need a whole hormonal profile and a number of investigations to decide whether the child belongs to any particular sex, or we'll have to look for the child's growth and development in general. Because like sir mentioned about Vishnu death. So sir mentioned about Shikhandi. In general, endocrinologists are very fond of mythology. So there was this, I do not know if gentlemen speaking have read this, but if this person, Amba wanted to be born to take this, whatever, revenge or whatever you call it, and Vishnu. So she was born as a female. This is a child who was born as a typical female looking child. And the child grew up. This is a child with XY, but was born like a typical female, was grown up as a female, and at around puberty, because there was so much, during puberty you have a surge of all the hormones. So the surge of hormones was so much testosterone that in the androgenetic pathway, it went beyond testosterone to dihydrotestosterone, and we describe Shikhandi as having pyrethroid reductase deficiency. This is what endocrinologists say. So you have a few androgen biosynthetic defects where they can have peripubertal virilization. This is another reason why you have to wait till the completion of puberty. To do anything drastic, you have to wait beyond 18 years, and beyond 16 years, even if you want to start any medical treatment, you have to take parental consent before you go ahead. So then in general, there are a few people who might not, like you mentioned, them a few disorders of sexual development, where this is something where they can be physically, they can appear to be something physically. This is all in the mind. What we are discussing today is all in the mind. It's about mental inclination. Some people, some might not have got exposed to testosterone at all. Okay, some males, like supposing I say there's a male child. Supposing I say there's a child who has a karyotype of XY and was born as a beautiful female, and when this girl grew up, this girl had typical female-looking genitalia. When this girl grew up, she had normal hilarity, and she had no acne at all, no body hair at all, no body hair except for the eyebrows, eyelashes, and the scalp hair, no body hair at all. How is this child present? And can you understand what kind of description I'm giving to this child? Have you heard of? Yeah, this child will present to you with primary amenorrhea. Isn't she very beautiful? Depending on the description that I've given, not a single acne mark on her face, no body hair at all, no tension of waxing or any kind of issues. So, what is the diagnosis for this child? This is complete androgen insensitivity syndrome. So, sometimes they may claim that this don't have any amenorrhea, but they might also present to you with some inguinal swellings. So, what are these inguinal swellings? Testes, they are the testes. Okay. So if you have partial androgen insensitivity, those testes can become malignant. But if you have complete androgen insensitivity, they won't even get malignant. But it's always good to get them removed. So you get them removed, and except for the fact, so this is something I always used to comment. The most beautiful females are actually males. Okay, they actually have XI. This is how they typically look like. So we have these people. They have complete androgen sensitivity. They have not been exposed to testosterone at any point in their life. So they think like females. They'll get married to males. So they think like females. Okay? So it depends on the androgen exposure. But then normal females also have androgens, and it is important that females have androgens. Okay? And it is important that males also have some amount of testosterone, have some estrogen. You know that all males have estrogen, right? Okay. What would happen if there is no estrogen in a male? Have you heard of aromatase deficiency? Aromatase is an enzyme which converts androgens into estrogen. What would happen if there is no estrogen? Estrogen is required for bone fusion. The child cannot continue to grow forever. Okay, the child would be very tall if the child has androgen aromatase deficiency. Okay, so both the hormones are required in both the sexes. Okay. So if you look at transgender, the prevalence is these are international estimates which say that it is 0.5 to 1.3% in birth assigned males and 0.4 to 1.2% in birth assigned females. So initially, like if there is any genital ambiguity, at least people have this inclination to given an option, tell a little rare children, at least people with a little orthodox background, let's say the child is a male child. Okay, so birth assigned males, the prevalence is relatively higher because they might have this female kind of mental thinking and inclination. So. So there might be a little bias when you are actually assigning the gender at birth. So this is why there has been recent inversion in these statistics, but this is at the international level. At the Indian level, UNDP funded a study called the IMRB study, in which if you look at this prevalence of transgender individuals, this is the prevalence. The highest prevalence is seen in these parts in Maharashtra, Andhra Pradesh, Tamil Nadu. Karnataka has medium kind of prevalence, and there is lesser prevalence in the northeastern states and in Chhattisgarh. Okay. So if you look at what happens to these people, I think you've heard of something called gharanas. In transgender people, there is something called gharanas because there's something called heritability. Heritability is something which is seen in transgender. There's a high heritability of 30 to 60%, and even if you look at twins, if you look at the transgender people, the prevalence in twins is up to 39%. So this is very common. And if you look at the biochemical defects, most people biochemically are normal because I told you it's all in the mind. But still, we've been trying to look at polymorphisms in androgen receptors, estrogen receptors, aromatase receptors, and there are most people think that it could probably be something related to some mild forms of CAH or mild forms of what is MAIS? You know CIS, complete androgen insensitivity. You might have heard of PAIS, partial androgen insensitivity. What is MAIS? MAIS is minimal androgen insensitivity. Usually these are the males who present with infertility. So that's minimal level. Okay, something below that, even milder, could cause people to think in the way transgenders think. This is what is hypothesized, but usually biochemically they do not have most of these problems. One particular problem could be sexual abuse or neglect of the child, which could cause the child to think in a different kind of way, or this could be associated with schizophrenia or autism. So these are the psychiatric disorders which could be the cause stem for these condition for this kind of thinking, and transgender kind of thinking could again lead to substance abuse disorders if not treated appropriately, if not addressed appropriately, which is why it is important to address this issue. And then we have now a number of environmental chemicals in plastics that we use, rampant use of plastics. So, and in plastics and pills and a number of chemicals which are being used. So we have phthalates and polychlorinated biphenyls. These are called endocrine disruptors. So these are present in very small levels in the environment, in our water, in our food, and could lead to the, in general, increased prevalence of that mild kind of genital ambiguity. So, if you have a person who comes to you who appears to be of a particular sex and wants that this person be addressed as something else, whether if the person wants to be identified as a third gender, we have a team. A team is required. It is a team effort of an endocrinologist, a psychiatrist, a gynecologist, a urologist, a plastic surgeon, medical social worker, and ENT people. Okay, so all of this is required, but firstly, we ask that because we want legal formalities first, we ask them to apply. This form which I have displayed. This form is available online. They can directly apply. Okay, they can take it through their through the office, and this is how they want to legally change their name. Firstly, to be identified as a third gender, and they can also change their name in accordance with the newer gender which they want to be assigned. Then the part of the team comes in. Then the endocrinologist will identify whether there is actually any hormonal problem, which is usually not the cause, but we always need to rule out if there is any mild condition, which is why the endocrinologist picture comes in, will get a hormonal profile, and if we want to start any other hormonal treatment also, we want to see if there are any absolute or relative contraindications. So for that we will go. And then for examination and for other things, gynecologist opinion. Examination again it matters. So who the patient is comfortable to be identified with, because their thinking might be otherwise. So we had a person who looked like a male, who was assigned a male at birth, who was gender assigned male at birth, who had come to our OPD, and my professor, he was sitting there, and I was a final year PG. So when we wanted to examine him, and I was trying to go out, the patient told sir that he's more comfortable with me, and he didn't want to be, he was shy to be examined by sir. Okay, so we need to again take their consent, their approval. So there, because of their inclination again, so gynecology people or the endocrinologist, then a psychiatrist needs to evaluate how much gender dysphoria they have, whether they actually have a problem or they're comfortable with it, whether they're comfortable with going ahead. So we have a questionnaire which they need to fill. The psychiatrist here is not to counsel them otherwise. Okay, it usually happens because there are so many legal hassles that people go ahead with counseling them otherwise. Instead, the psychiatrist is to give them a questionnaire, fill it up, and identify what is their inclination, and depending on them, that guide them accordingly. So again, if they want any reconstructive surgeries accordingly, the role of the urologist, and for implants and other kinds of things, the plastic surgeon's role, and if they want their voice to be changed accordingly, the role of the ENT specialist comes in. So to initiate treatment, usually once they start thinking in a particular way with, during the initiation of puberty, they would want to be identified in that particular way. But then, like, as I told you, till 16 years, there's nothing that we can do. All we can do is, if their puberty is troubling them, we can stop their puberty. Okay, so we just halt their puberty by a GnRH agonist. Okay, so all we give, all at least leuprolide is something which is easily available in India. So we'll go ahead with leuprolide, and the treatment is reversible because people can be again gender fluid or under some kind of influence if they are. So after the psychiatrist evaluates until the child is of age 16, we'll give GnRH agonist. Okay, and then once we start treatment, there are a few things that we monitor. Will physical parameters and biochemical parameters will be monitored. The problem with delaying in treatment is that it can lead to gender this gender incongruence. Sorry for the typo. It actually causes gender dysphoria. The incongruence can cause gender dysphoria. It can be detrimental to bone health because bone strength. What is it which causes bone strength? Like I mentioned, it is the sex hormones which cause bone strength, right? Which is why postmenopausal people will treat. Okay, so estrogen is required for bone strength. So this can be detrimental, and even for people who have testosterone, ultimately the bone strength is because of the aromatase activity which is being converted to estrogen. So it is detrimental to bone health and fertility prospects. You are halting the germ cell development either in the testis or in the ovary. So this can be detrimental to fertility prospects. and this can isolate the child from age-matched peers. Okay, so the child all these years, so here, if the child starts this kind, having this kind of thinking at the age of around 12 till 16, for the next 4 years, he cannot gel with the people he wants to gel with, who he thinks are people of his particular sex, of his particular gender. And if they are started on treatment, then the well-being is equal to or greater than the age-matched controls from the general population. So it is, if everything goes well, then it is good to treat them, and then the bone age would gradually improve. But till we give them any GNRH evidence, it is good to ensure adequate calcium, vitamin D intake, and that we have to ensure that they do adequate exercise. Okay, this is the age where you, okay, the importance of exercise at this age cannot be underestimated. This is something which we learned probably during our final year exam in DM, which is why it is important to tell people at this age group. When people say that you play and when you do exercise your bone strength increases, it actually increases. You might stop growing by the age of 18 or 20, but your bone strength continues to grow, your bone mineral density continues to grow till the age of 30. Okay, so it is important to do exercise at this age group to make sure that your bones are strong. Okay, then when we determine bone mineral density, we look at those sex charts and determine based on that. So for these people who don't conform to a particular gender, what we call this is bone mineral apparent density. So this bone mineral apparent density is relatively lower because again their puberty is being suppressed. Okay. So again, fertility prospects which I mentioned. So before we start treatment, we look for other contraindications. We look at whether they have migraine. These are all your contraindications many people know. For starting OCTs, all the contraindications that we look at: migraine with aura, smoking, uncontrolled diabetes, hypertension, dyslipidemia, substance abuse, clotting risk, immobilization, stroke, breast cancer, pregnancy, vaginal bleeding, liver disease, any endometrial abnormalities, vaginal bleeding. So all these things you'll rule out before starting estrogen for these patients. Hormone analysis, like already mentioned. Then when you start treatment, again you'll follow up with those things like I mentioned, with the physical parameters, height, weight, other things, then the radiological parameters, BMD, the bone age of the child, and biochemically, lipid profile. Again, these hormones will have effect on the HDL levels, on the triglyceride levels, so on the clotting risk. So we look at the lipid profile and LFT. LFT for any patient, for any person who started on testosterone, we will monitor the hematocrit. We do not want the hematocrit to shoot. And LFT. LFT monitoring is not mandatory for people on estrogens, but it is required for those on testosterone. Okay. And when we look at the disease-related risks, the disease-related risks might not be grossly different, but again, using these medications might pose some additional risks. And if you look at cancer prevalence, this is something which is very obvious, but might look a little confusing, which is why I have mentioned this. Simply because they underwent a surgery and if there's a female who wants to be addressed as a male, so if there's a trans male, so because she has a cervix, her risk of cervical cancer will be the same. Not that because now this person is not a female but a male, the risk of cervical cancer is less. That risk will remain the same. And again, when you look at the risk of breast cancer, uh, if there is there is still a trans woman who has breast implants or who has undergone any treatment to become a female is actually was basically gender assigned male at birth. So this risk in a trans woman is relatively lesser than in a cisgender woman, than in a normal woman. Okay, so you get the thing. Male less risk, trans medium risk, female maximum risk. Okay, so the risk for a male who came to this stage will be relatively greater. For a female who became that would be relatively lesser, but not as the person of the completely opposite sex. Okay. And then we start treatment. Initially, like I mentioned, leuprolide is something which we use 3.75 mg subcutaneous. For people who have given this injection, you know this is a very painful injection. You have to change the needle and give it in the thigh intramuscularly. Or we now have depot preparations, 11.25 mg subcutaneous depot once in every 3 months. Then starting testosterone and estrogen. Estrogen, gynecologists might be well aware of the clotting risks with estrogen. So ethinyl estradiol, we are all a little apprehensive. Now we have something called Proganova. Proganova is estradiol valerate, which is available, which doesn't pose much of a clotting risk. So this is something which we give comfortably. We start off with 0.25 mg once daily and gradually increase the dose. You can escalate the dose very fast if you want rapid puberty, but the problem is You want the person to be looking as female looking as possible. This dose escalation is something which we use for initiation of puberty. For a male person who wants to be identified as a female, you can start off with 1 mg. But it is always good to take your time and gradually escalate the dose. Otherwise, the breast development might be tubular, but actually come out as a tube instead of the proper feminine kind of contour. Then you have transdermal patches as well, which are not very easily available. Probenoma is something which is easily available. And anti-androgens are also started. So you can start on ciprofloxacin or spironolactone. Okay, I'll come back to this. Then, when we talk about testosterone treatment, you have testosterone, which can be given once in every 2 months. And then initially, this is how you build the dose, how you start up with a treatment, and then you can go to the mixed longer acting kind of preparations, and finally you can go to depot preparations, which can be given once in every 3 months. You have gels also, but when you put male patients on gels, you need to be careful that they don't get in contact with the other females in the family. Okay, so this is one thing. Like sir mentioned, what are the causes for postmenopausal hirsutism? When there is postmenopausal hirsutism, there could be some other. I mean, that was a very clear-cut case because it was such huge levels of testosterone. But a few other causes could have also been the exposure to androgen. Some other male in the family might be using some testosterone gel, and these people might have got exposed to because of using same towels or things like that. Okay. So anti-androgens. This one slide about spironolactone I've mentioned because this was asked in my final year MD general medicine exam. So I thought this was something which was the deal breaker for me, which gave me some extra edge. So how is it that spironolactone causes gynecomastia? We use this in chronic liver disease, right? Cirrhosis. So general medicine people, spironolactone anti-androgenic kind of action and gynecomastia is by antagonism of androgen receptors, increased clearance of testosterone, increased conversion of testosterone to estradiol, and direct inhibition of testosterone production. You can just take a photo. This will be very useful for MD medicine people. I didn't get this at the MD level. I only answered 2 or 3 of this. Okay. So then, at the end of everything, then you can go ahead beyond the age of 18 years. Even for starting treatment, medical treatment can be partially reversible. So this will start between 16 to 18 years. We give it for 2 years with parental consent. And after the consent, then we can go ahead with surgery beyond the age of 18 years. After 2 psychiatrists have documented that you can go ahead. Okay. Then you have something called feminizing surgeries and masculinizing surgeries, which are usually done by the plastic surgeons. So for people who want feminizing kind of body structure, you can go ahead with breast augmentation, facial feminization surgery, genital surgery, vaginoplasty, orchidectomy, and tracheal shape. This is where the role of ENT people comes in. You have something called tracheal shape to make the voice also more feminine. Then you have masculinizing surgeries, mastectomy, facial masculinization surgery, hysterectomy, salpingectomy, oophorectomy, metoidoplasty, and phalloplasty. So phalloplasty is something which is a little difficult, which is why I mentioned it is easier to make someone look like a female than to make someone look like a male. Then you have something called this National Legal Services Authority of India. I don't know if you know this or not. Now they have, there is this concept of giving OBC reservation to people who identify as transgender. Okay, so like one of the spotters was about the famous transgender people. Most people might be knowing this person called Lakshminarayan Tripathi. I think she had come in KBC and a few big platforms. So Lakshminarayan Tripathi was the one who spearheaded this, and now they have some reservations as well for them. Thank you. Welcome to education.
Thank you, ma'am, for introducing us to the very recent and controversial topic too much followed on social media, the trans. I would like to invite Dr. Swaraj sir to felicitate Dr. Gayatri ma'am. Thank you, sir. Thank you, ma'am. I did request Dr. Mananda ma'am to please felicitate all the quiz masters for the day. Dr. Swaraj sir. Dr. Soumya ma'am.
Ready? I'd like Dr. Palaji ma'am to give away the prizes for the quiz winners. So team Tungabhadra with 85 points are the winners. And second is Krishna, and then Kaveri, Bhima, Godavari. Thanks a lot for all the students from all the medical colleges for coming and participating in this. Thanks, we had a very good time having you here.
Paladina, please wait. I request you to present the mementos to all the participants because they have worked so hard. Team Kaveri, please come. Team Krishna. Team Bhima. Team Godavari. And Team Sharavati. Thank you for coordinating so well. You can continue fighting in your wards. Coming to e-posters prize distribution, which was conducted on July 11th. The first prize goes to Dr. Arpita Dandagi. Yeah, please come. I request Dr. Palaji ma'am to distribute the e-poster. Dr. Palaji ma'am, e-poster certificates. First prize, Dr. Arpita Dandagi. Second prize, Dr. Malika. If she is here, otherwise one of our friends can please collect it. Third prize, Dr. Mubashra. I think she is also not there. Please select it on her behalf. And the consolation prize goes to Dr. Sushma. We are already late.
Good afternoon, everybody. I think we started with good morning, it's good afternoon, and we're still running away with 2 hour session. So we are going to wind up now. We're going to have a delicious lunch as promised in the brochure. At the outset, I'd like to thank Department of OBG and Department of Medicine and the respective HODs for giving us this opportunity to have a thing which has not been done. So it has its own set of challenges that we face. But I think at the end of the day, we were able to do a little bit of justice to what we wanted to do. I would like to thank Dr. Manana ma'am for bearing with me for the past 2 days. A lot of administrative issues were there. I think we had to come over that. We did that. Thanks a lot, ma'am. Dr. Balaji ma'am for being here from the start till the end. Thanks a lot, ma'am, for being here. And I'd like to thank Dean sir in his absence for always being encouraging and helping us through such activities. Dr. Anita, thank you for being patient with us. And thank you for not forcing me to give a question which I did not want to. Thank you. Thank you one and all. And at the end, thanks to all the postgraduates from all the medical colleges for coming here and having participated. Thanks a lot.